Ladies and gentlemen, we are so sorry and disappointed not to be here today. Nevertheless, it's a great honor for us to be there with you for this debate. The anesthesia protocol for colectomy, ambulatory colectomy, integrates all the ARES items, but today I will only underline some of them. First, we have to provide an adequate anesthesia during all the surgery without residual sedative effect. That means to avoid premedication, anxiolytic premedication, to use short-acting drugs, and to provide a deep muscle relaxation during all the surgical procedure, and to monitor everything. The second point is the nausea and vomiting prevention. Post-operative nausea and vomiting is a complication very distressing for the patient and could make impossible their discharge. The first prevention is a limited fasting period with clear fluids and sugar intake 2 hours before surgery. Then, anti-emetic agent and different emetic agents must be used. The third point is the hypothermia prevention. Hypothermia increases bleeding, cardiac and infectious risk. So, forced air, blankets and mattresses must be used and the fluids must be warmed. But the most important item is to provide an optimal, oral and opioid-free post-operative pain relief. The analgesia must be initiated very quickly after the surgical incision and must use different agents to act on the multiple pathway of pain. In our protocol, the opioid must and can be avoided if the patients are convinced that they are the central actors of their postoperative pain management and that all the painkillers must be taken on a regular basis. In our protocol, after discharge, there are no opioids, and that provides an optimal and adequate analgesia in most of our 200 ambulatory colectomy patients. Thank you for your attention.
Ladies and gentlemen, we are so disappointed not to be with you for Success of Las Vegas, but we are not allowed to travel in US because of sanitary reasons. We are very pleased to share our experience about ambulatory colectomy in this great debate. Here my disclosure, and I want to focus on 4 points. First, it's a teamwork concerning surgeon, anesthesiologist, nurses, and patient. It's very important to associate patient with the whole stage of management. ERAS program reduces hospital stay, but ambulatory process requires specific knowledge and skills. Try to perform ambulatory colectomy in a normal unit. It's a lack of chance. We'll focus on home follow-up at the end. Second very important point is patient information. Patients have to understand all the procedure, before surgical day, during and after. You must be confident with notion of risk, and we have to explain all follow-up basis. When it's possible, relative must be associated in this explanation process. During surgical consultation, it seems not possible to give all this information. So it is very important to split the message between surgeon, anesthesiologist, and ERAS nurse-specific consultation. Third point, about surgical procedure. This is normal laparoscopic colectomy following all ERAS recommendations. We perform intracorporeal anastomosis for right and transverse colectomy with suprapubian extraction. Discharge criteria are very simple. 6 hours after surgery, patient must be less tired than surgeon. But if any doubt or problem, patient have to stay in the hospital. Unscheduled hospitalization are not a fail, it's an option. And last point, about home follow-up. It is mandatory to propose home nurse follow-up after hospital discharge. You have to write your own team algorithm, depending of your local condition, distance, specificity, city or country, possible traffic jam, as you want. It's fundamental to build a local solution for each problem. Patient must have 24 hours a day link with your structure, and patient data must be collected every day for the surgeon. In France, we have explored 2 different options: digital link by app or phone link. We have 2 different centers with 200 procedures in each, and there is no advantage in one specific link. Both are equal. And my last message: after hospital discharge, ambulatory process or short ERAS procedure have the same risk. So, for my part, I recommend the same follow-up for all patients, whatever the length of hospitalization. Thank you for your attention, and I will be very pleased to exchange by mail, and you have it on my first slide, or later in a future SAGES Congress in 1 year.